Okay, and I'll hit *1 and we'll open up a line, all right? And then I'll go to my spiel. All right, so 5, 4, 3, 2, 1.
The broadcast is now starting. All attendees are in listen-only mode.
Hello, thank you for joining today's webinar. This is John Howlett with Kaufman Hall, and here with me are Dr. Robert Pryor and Dr. Matthew Lambert from Kaufman Hall's Physician Strategy Team. Drawing on decades of experience as physicians, administrators, board members, and educators, Dr. Pryor and Dr. Lambert will be sharing their insight on how physician leaders can engage the medical staff in the transition to value-based care. Before we get into the presentation, I want to quickly review a few housekeeping items. Whether you're listening through your computer or via the conference line, all attendees will be in listen-only mode for the duration of the webinar. Those participating through their computer will have the ability to send questions to us through the questions pane on your attendee interface. Simply type in your question and click send. At the end of the presentation, we will answer as many questions as we have time for. If your question is not addressed during Q&A, we'll be sure to follow up with you afterward. Please note that material related to the issues we'll be covering today, including the presentation, is accessible within the handouts area of the attendee interface. As a final note, today's webinar is being recorded, and everyone will receive an email within 24 hours with a link to view the recording. Any of your colleagues who registered for the webinar but were not able to attend will also receive the link to the recording, and the recording will be posted to the events section of kaufmanhall.com as well as an on-demand webinar. With that, I'll turn it over to Dr. Pryor.
Thank you, and thanks to everyone for joining us today. So today we're going to look at how to understand what's going on in value-based arrangements, and then how do we engage physician colleagues in productive discussions and initiatives related to the value-based payment that's coming. With that, we'll be discussing change management and change as conflict, and then we'll have time for questions and answers. So first of all, let's talk about understanding what these value-based arrangements are. But before we can actually ask people to change, we really need to have an understanding of what we want them to change to. This slide of Bob Dylan, because I'm a child of the late 60s, really spoke to me because the times they are changing. We're going from times in healthcare where we absolutely could see the pathway that we're on and actually knew how to get from one place to the next as far as what to do for our patients, how we're going to be reimbursed, and what's expected of us. But now things are changing. The next slide is one of the books that I really like. It's Who Moved My Cheese? And in this book, it talks about two types of scurrying animals. One who would continually look for where their cheese went, and the other one who were complacent and were staying in place and deciding that their cheese was very important. And the one thing that they make is that the more important the cheese is to you, the more you want to hold on to it, and the less likely you are to go to look for new cheese until sometimes it's too late. Now the good news in value-based purchasing is we absolutely know where the cheese is moving, or at least we've been given some clues of where the cheese is being moved toward. So we're going from being reimbursed by paid for volume to being reimbursed by pay for value. And we'll talk a little bit about the nuances of that in just a minute. I'd like to divide that into two categories. What's going on in hospital payments, which all physicians are participating in, and then what's coming down, which is primarily going to affect the physician payments. So first of all, what is exactly pay for performance? Well, it's an alternative to fee for service. It gives financial incentives to clinicians for better health outcomes. Now, the problem is that true clinical outcomes, such as longer survival rates, are too difficult to measure. So the pay for performance system typically goes up the chain and measures process outcomes, such as measuring blood pressure and controlling that blood pressure to lower the blood pressure to predictable and stable values. And looking toward a particular lab value, such as a target hemoglobin A1C, or looking for smoking cessation, which gives better health outcomes in the long run. So let's take some time to look at a little bit about where hospital pay for performance is going toward. So if you look at the graph, it looks at going from the least risky to the most financial risk on the continuum. So first of all, let's talk a little bit about where we are today, fee for service. This is something that we all understand because it's a transaction. we either see a patient and we do a cognitive process, and we diagnose and we treat, or we do a procedure, and there are certain fee schedules that we're accustomed to using, and we charge a fee for certain types of activities that we perform with patients. And with this, we remember that the medical ethics, and we do what's necessary for our patients, and it's one patient at a time with one physician, generally in an exam room or a procedure room. The fee-for-service is going away, and we're moving toward things such as reference pricing. Reference pricing is the next level up of more financial risk. In reference pricing, the insurers provide a defined contribution toward the full price of a procedure. The patient may seek services from a provider with a higher price, but the patient is responsible for the difference between the defined contribution that their employer pays and the actual cost they pay for the procedure. So it's passing risk on to both the health system, the physicians, and also to the patients. The next one is variable provider payment updates. And in variable provider payment updates, the providers delivering higher value receive a larger payment update than those delivering lower value care. Of course, this may be difficult to administer without having a common definition of what is value across all payers and providers. And it's not really conducive to provider integration and care if the care coordination is based upon the old fee-for-service method in addition to that. The next is shared savings, and we'll talk about this when we get to physician-specific payment as well. And in shared savings, after an established baseline of annual per-patient cost, provider systems and payers share in the savings generated if the per-patient costs come in below the baseline while maintaining or improving quality outcomes. Now, the problem with shared savings was that the organizations that had really low baseline cost and high quality really got nothing out of the shared savings program. And the incentives weren't quite aligned with improving quality across the board. The next is patient-centered medical homes. And this is another physician-centric payment where the patients, particularly those with chronic conditions, choose a medical home for their primary care and care management. The medical home operates in a mixed fee-for-service and bundle payment environment. Monthly bundled care coordination payments coupled with fee-for-service payments for office visits are distributed. The next one is bundle payments, and there are certain pilot projects across the country now, especially in joints, where there are bundle payments occurring. So in a bundle payment, a single payment to providers for healthcare facilities, jointly or to both, for all services to treat a given condition or provide a given treatment. The bundle payment asks providers to assume financial risk for the cost of services for a particular treatment or condition, as well as the costs associated with preventable complications. And then going to the full, most at risk is full capitation. And in full capitation, the payment that's delivered to the provider covers the entire packages of services negotiated between the purchaser and the provider for enrolled population. This, of course, includes all types of complications, and you're responsible for all types of the risk. The next slide takes us into the more physician-centered incentive pay. And looking at what's coming on to the horizon, this source is from Sullivan Cotter and Associates, and they predict that incentive pay, which is currently about 3 to 5% of total compensation in many employee compensation models, would be expected to increase to more than 10% over the next few years. And as this is increasing, the yearly adjustments in physician pay would be congruent and consistent with the payment structures that the system is being compensated for, the services. So the CMS has some concepts in value-based purchasing, which may be a little bit differently than what we've been thinking as physicians. First of all, the providers are accountable for both the cost and quality of care. The value-based purchasing brings together information on quality and cost of care that's delivered, and the payment is adjusted accordingly. It focuses on managing the system to reduce inappropriate care or inappropriate clinical variations and to identify and reward the best performing providers, while it actually is designed to penalize the more poorly performing providers. So going historically in order, the programs that are affecting physician reimbursement, first we started with meaningful use. And if you remember the way that started, you were given some money if you reported your data. And then, of course, that's changed as the years have gone by. And meaningful use was the implementation of use of electronic health records and gave incentives and reductions in total Medicare payments. It had a little bit of delays built in, but it's been fully going for several years now. The PQRS system, the Physician Quality Reporting System, was the one that you were actually paid for reporting first. It's to track, evaluate, improve the quality of care. And it started with voluntary reporting and incentives, and it has progressive penalties included. The value-based reimbursement modifier shows differential payments to physicians or groups based upon the quality of care compared to the cost of care that they're providing. So let's go back and talk a little bit more about physician reimbursement. So shared savings we talked about before. Shared savings is the sharing of savings to a baseline. Then accountable care organizations, which are reliant on the patient experience, care coordination and patient safety, preventative health measures, and care of the at-risk population. That is, patients with certain chronic illnesses such as diabetes, hypertension, ischemic vascular disease, heart failure, coronary disease, asthma, etc. We account for a management of the care of these patients to reduce the care of the most expensive patients. Bundle payments, we talked about it under the hospital formulas. And then as we go to the future, we're looking at the next generation ACO model. And in the next gen model, there is more downside risk than the current ACO models that most of us have been involved with. The 6 basic principles of the model include is to protect the Medicare fee-for-service beneficiaries' freedom of choice. If you remember back during the experiments of health maintenance organization, the one thing that people did not like about HMOs was the abridgment of their freedom to choose their providers. The second is this allows beneficiaries a choice in their alignment with an ACO. It creates a financial model with long-term sustainability for the Medicare plan. It uses a prospective set of benchmarks. It offers benefit enhancements that directly improve the patient experience and supports the coordination of care. And it smooths the ACO cash flow and improves the investment capabilities through the alternative payment mechanism. So that's what it's designed to do, and we'll get to APMs in just a minute. So in the realm of be careful what you ask for, we asked for the fix to the SGR problem, and they did come up with a fix to that, and it's called the Medicare Access and CHIP Reauthorization Act of 2015. And this gives us MIPS and APS. So the Merit-Based Incentive Payment System, or MIPS, comes from the Act of 2015, and it's divided into performance categories with maximum points and percent of the score. Now, I'll say this several times, the year 1 of collecting information is coming up in January of 2017. That's just around the corner. So that kind of builds the burning platform of what we're talking about today is improving the ability to understand the complications of the pay for performance that's coming. So it relies on quality, advancing care information, clinical practice improvement activities, and cost. And that's 50%, 25%, 15%, and 10%. So how do the payment adjustments look over the next few years? So they start collecting data in 2017, but in 2019 it's plus or minus 4% adjusted on the Part B payments to clinicians. By 2020, it's plus or minus 5%. By 2021, it's plus or minus 7%. And then after 2021 and onward, it's plus or minus 9%. So you can get an 18% swing in Part B Medicare payments to clinicians. The alternative payment model will be available to those physicians who are enrolled in a model that produces a significant downside risk of financial. So the APM is the other part of the program, and the participants must use electronic health record technology. It bases the payment on quality measures that's comparable to those in the MIPS quality performance category, and it requires either the alternate payment entity bear more than the nominal financial risk for monetary losses, and or a medical home model expanded under the CMS Innovation Authority. Qualified participants will receive a 5% lump sum bonus, applies from 19 to 24, and then they receive a higher fee schedule updates starting in 2026. So as I've looked out and discussed this with physician colleagues, I found that there's a lot of inertia related to actually climbing on to the new payment models. As a matter of fact, when I was talking to one surgeon, he told me that, gee, Bob, I really don't need to be bothered with this because you don't understand. I'm a small business owner, and everything that I'm worried about is how am I going to maintain my small business. I don't really have time to worry about all the things you're talking about. But as far as the way that we lead physicians, physician leadership is best done by other physicians. So Matt is going to talk to us a little bit about how we can involve physician-to-physician leadership and encourage physicians in a productive discussion in the value-based payment. So Matt?
Thanks, Bob, and thanks, John, for moderating this session. You know, before I get started, I just want to say I recognize that on the phone there are a lot of very experienced physicians, physician executives, maybe perhaps some hospital executives and some financial people who are dealing with the issue of trying to engage and motivate their physician populations to begin to think more coherently about what Bob has talked about. So what I'm going to talk to you about today is some general principles. Some of these things you may already be doing, but I hope that there'll be some pearls in here somewhere for you that might be beneficial as you begin to work with your medical staffs and employed practices or independent physicians. I think to start off with, we would like to talk a little bit about some of the terms that we're going to be using today so we're all on the same page. We're going to talk a little bit about motivation, we're going to talk a little bit about engagement, and we're going to talk a little about alignment, and parenthetically talk a little bit about satisfaction. So when we talk about motivation, when we talk about motivating physicians to begin to think and engage in value-based payment, it really is the process by which physicians are goal-oriented with respect to that kind of behavior, and it sort of initiates and helps move physicians along a track towards understanding and the goal of value-based care. There are basically four ways to motivate anybody: extrinsically, either internally, intrinsic motivation, extrinsic positive motivation in the form of a bonus or financial payments, extrinsic negative motivation by coercion or threatening termination, things along that line. Intrinsic positive motivation is a thing that most physicians have. Professional pride in what they do, their commitment to patients. It's one thing that physicians essentially have as soon as they embark on a career in medicine. And then, of course, there's the intrinsic negative motivation where physicians and others are motivated in a negative fashion by sort of moral aversion. But the point is that although a lot of organizations try extrinsic motivation to get physicians on board with respect to value-based care, it really doesn't work. Positive or negative extrinsic motivation is really not effective, except in situations where they're relatively simple tasks, relatively menial. If somebody digging a ditch and you pay them a little extra money to dig it quicker, they'll do it. But for more complex things, it just doesn't work. Extrinsic motivation, especially when we're talking about compensation or bonuses or things along that line, is just not sustainable over the long run and really does have diminishing returns and ultimately has a retarding effect on the intrinsic motivation that you'd like to encourage. But the types of motivation I think that perhaps Bob has found, and I know I've found that does work when you're dealing with physicians, is to offer them an opportunity to really control the process that you're engaging with them about, challenging them to come up with different ways of doing it that are satisfactory not only to the organization but also to the physician community. Recognition is very important. A cooperative posture between organization and physicians, and building trust among all the parties. And we'll talk about that in more detail a little bit later. Moving on to engagement, this is something that's been sort of a buzzword since the mid-1990s. There was an article in Harvard Business Review that showed that employee engagement improved customer retention and sales, and since that time it's sort of migrated to talking about employees in the healthcare sector and has migrated into the physician community also. The interesting thing is that when you look at physicians and you begin to take surveys, you find that engagement as defined as being a passion and commitment to an organization or their job and the ability to deliver on an organization's objectives is really, at an all-time low. I think at any given time, perhaps 1 out of every 3 physicians, if you talk to them, are expressing symptoms of burnout. If you do large-scale surveys of physicians, about 60% of them would say that if they had the ability to retire the day you're talking to them, they would retire. And when you broaden this to employees in general, you find that only about 1/3 of employees nationwide really like the jobs that they do. So what you really want to try to do when you talk about engagement, engagement really is a passion and a commitment, whether it's in a physician or employee, to the organization as well as their job. And it's really a willingness to engage in sacrificing some of their discretionary time for the good of the organization. And it's really not a transactional effort, really. It requires relationships. It requires sort of emotional attachment, emotional intelligence, and it really evidences a real connection between the employee and the organization. Now, one has to understand the difference between engagement and satisfaction. And there is sort of a misinterpretation of these two terms, and a lot of times we find that efforts that organizations are using are really more in the satisfaction area rather than the engagement arena. Satisfaction is really to the extent to which employees are happy and content with their work and their work environment. You can have employees or physicians that really enjoy their work but aren't really engaged with the organization at large. And the problem is that what we see is that many organizations are using satisfaction-inducing methods like improving the compensation, offering additional education, team building. All of these things are important, but they really don't do very much with regard to physician engagement. The next thing I just want to define a little bit is alignment. Now, alignment really is sort of a tricky thing to talk about, and it really is a mechanism by which the organization creates structures or a dynamic that fits the requirements of both the physician and the organization. It really, it's not a one-way street. I think in my view, these terms like engagement and alignment, they're almost pejorative terms to physicians in some respects. They're talked about as if they were a one-way street, that physicians are oriented towards the organization, but really all of these things are two-way streets. They have to work for both parties if they're going to be successful. Alignment is extraordinarily hard to achieve because the environments in which your organizations are competing are very, very fluid. I mean, if you take a look at just the organizational structure and the organizational leadership, it's a wonder that we're able to do anything at all. I mean, if the average CEO, the average hospital CEO in the United States now has a tenure of less than 4 years. And out of those people that are in that relatively short period of time, over half of them are terminated involuntarily. And when a new CEO comes in, within about 9 months, half of the CFOs, half of the COOs, and half of the CIOs are dismissed and replaced with somebody else. The CMOs even have a more difficult dynamic in that almost 90% of them are replaced within a couple of months of a new CEO joining an organization. So all of this creates a significant degree of instability in an organization when you're trying to deal with very important elements like engagement and alignment. So for those of you that are charged with this responsibility, it's very, very difficult. And it's difficult in addition because you're asking people to make changes for a potential outcome. And you're asking them to advance the organization's well-being in some respects at the expense of their own. So when you look at what makes the professional organizations like the medical staff or the clinic structure or the owned and operated practices so different from organizations, there are a couple of tables in the next couple of slides that I won't go through in detail, but basically they show this is a cultural divide between the profession of medicine and the profession of management, and they have to do with how the motivation is defined, the organizational structure. All of these things are very, very different. And when you move along to things like decision making and communication, we all know as physicians that we're an expert culture, and we tend to relate to other physicians as experts in and of themselves. We treat them as equals, they treat us as equals. So the lack of a hierarchical culture and beginning to integrate with a administrative culture is very difficult and really requires some significant understanding. So over a number of years now, my own personal view is that as opposed to cultural change, which a lot of people talk about, I'm actually very much in favor of the concept of cultural integration. The physician culture, depending on how you define it, could be a couple of thousand years old, or if you really take it to the time where organized medicine came into the fore, or the real training became more systematized, it's at least several hundred years old, as opposed to the administrative culture, which really began in the 1930s here in the United States. So what I believe is really important, it's like moving into a foreign country. You maintain your culture, but you want to adapt to the culture in which you're living. So we're talking here about cultural integration, not necessarily cultural change. And along with that is sort of coexistence and understanding, which involves greater communication and dialogue. And dialogue really, it's a Greek word, but a sharing of ideas, which is extremely critical, for this idea of engaging and motivating physicians. So talking a little bit about change management, and Bob alluded to that earlier, and this is probably the most difficult thing to do in any organization, whether you're dealing with physicians, employees, consumers, whatever. But we know that change can occur easily when we want change to happen. We do it all the time. All of us in our lives, we've changed our lives when we got married and had kids. If we did that, our wives were kind enough to change their name and things along that line in most cases. So when we want the change to happen, change is really pretty easy. We also don't mind change when we understand why it is happening, and also when we're actually in controlling the change. But in many cases, I think physicians feel that a lot of things have been taken away from them, and they really haven't had an opportunity to control the process of change, and oftentimes we do a very poor job of explaining to them why the change is necessary. It also can be very, very difficult when people are frustrated and angry. And I already mentioned to you that when you look at physicians, how unhappy they are and how disillusioned about the practice of medicine, that is a tough group to change. And also, sometimes you find in a minority of cases, when physicians are having a great time, they got a great fee-for-service deal, they're making a lot of money, they're really not challenged, the competitive environment is relatively low, then those people are not interested in change. So the two extremes, people are extraordinarily unhappy or disillusioned, or people are very happy and they're not interested in changing. So I think that getting physicians to begin to view the transformation from fee-for-service to fee-for-value really it requires that organizations spend a lot of time listening to physicians to try to understand exactly what their concerns are about this, and this takes a lot of time. It cannot be done by an email, by a memo, by a mass meeting of the medical staff. It does require an intense one-on-one relationship between the leadership of the organization and every physician that's willing to sit down and talk to you about it. Leadership of organizations really has to understand that trust is the most significant factor for achieving that kind of sustainable relationship. And as I mentioned earlier, it's very, very difficult in this kind of environment where there's such a significant turnover of leadership in most organizations on a relatively short basis. So these are things, at least for the chief medical officers and for those physician executives charged with this responsibility, why it's important to spend a lot of time listening and doing a lot of one-on-one. Making physicians feel empowered is extraordinarily important, and you can do this by helping them better understand the environment, by educating them to the extent that you can, sharing the power in the information. I think for me personally, my most stimulating part of my career was when I realized that I had no power over everything. I had a lot of influence, but I really didn't have a lot of power. So you can go ahead and make a lot of connections for these physicians to help them become better educated, better informed, better able to navigate in this environment, and most importantly, making sure that their locus of control is enlarged, that they get to do more things within their practices and without, and they have a ready vehicle to provide input to you going forward, and making sure whatever you ask them to do is relevant. Now, conflict is inherent in this whole change management process, but it's especially an integral part of healthcare pretty much every day. I mean, every physician, every clinician engages in sort of a conflict-ridden environment just by the nature of the patient care we deliver. The environment is often ambiguous, it's complex, there's competition among physicians, evaluation of patients by patients of physicians. There's constant change, and the stress and pressure of the practice of medicine is sort of undeniable. So these things, set up a sort of a conflicted environment that's very, very difficult, to operate within, especially when we're trying to do something that's essential for the organization's well-being, like getting everybody on the same page about value-based care. So what we need to do is really help change our perception of conflict and begin to accept it, and realizes that the continuation of choices and conflict is really sort of unacceptable and has some untoward consequences. So there is an opportunity for everybody to learn in this kind of environment, this type of education, moving from volume to value, and helping eliminate some of the misperceptions that Bob talked about. Especially for physicians, it's helpful when they begin to see themselves as part of the system and not standing outside of it, that there isn't some enemy outside that basically is doing this all to them or to the organizations. It really is looking for a common purpose and sort of anticipating the conflict and getting along and moving along with it. So my final two comments really have to do with this issue of negotiation, which I look upon this kind of change management is really a negotiation. And this sort of walk in the woods concept came from the 1980s arms negotiation between the United States and the Soviet Union. And it really is a form of structured negotiation and conflict resolution. And I think anybody who's in a leadership role should spend some time developing some skills at negotiation, attending some classes or courses on this. But really what you're trying to do is interact and bargain on the basis of shared goals and objectives. So with the goal of improving effectiveness, efficiency, and satisfaction of the process. You're really trying to focus on the interest and motives and objectives of both parties. So this idea of moving from volume to value is a negotiated process. We have to understand that the rules of the game have changed. They've changed for physicians in a very dramatic way, and part of it is seeking to understand. So what we're talking about here is a transition to a multidimensional approach. Initially, everybody has self-interest. A lot of physicians, unfortunately, come to this idea, or maybe even people from organizations, in sort of a unidimensional approach to negotiation. It's either my way or the highway, or a bidimensional negotiation where somebody wins and somebody loses. And those things are really unfortunate because they don't really advance anything. And basically, they lead to a lot of recriminations and a lot of failed efforts. So initially, what we want to do when we get together with the physicians, and again, I stress this importance of being one-on-one, that it's important at the beginning that each party, the organization and the physicians, have an opportunity to express their own self-interest as well as hear and appreciate the self-interest of others. And at the end of that first phase, there really is an appreciation of the legitimate differences that exist between the two parties. And there's a broader definition of the shared problem. We're moving on to the next phase where the interest is somewhat enlarged in that we reframe the understanding, we find out what they're actually negotiating, and we shift to a more multidimensional problem-solving perspective that reframes the unidimensional or two-dimensional point of view to a broader frame. And the end point, what we do at this second phase is begin to list, first of all those areas in which both parties agree upon, and then later going on to those elements that are areas of disagreements. But at the end of the time, we've come up with a bigger picture of the work to be done, and there's a suggestion of the possibilities that might be achieved with ongoing negotiation. Moving on, we go to enlightened interest. And here we generate fresh and innovative ideas about this process. How can we basically move to a value-based environment? What do we need to do? And what's the brainstorming and the ideas that can be generated by both parties to enable this? And what we do then is each party then begins to offer ideas or things that could be done, innovative solutions to this. And then there's a series of negotiations on which are the most prominent. So you get the experience of negotiating with one another. And then finally, we get to the point, hopefully, where the interests become aligned, where the gives and gets are adequately described, they're defined, and they're ranked. Each party understands what they're eager to give up, what they're willing to give up, what they're unwilling to give up, and then fleshing out the exchange and ultimately come to some sort of negotiated agreement. So, this part of negotiation, which we think of in a more formal way, is certainly very much a part of this whole movement of physicians from volume to value. But I will emphasize in concluding here that it is extremely important that this not be short-circuited in any way. It requires an intense amount of effort on the organization, on the leadership of the organization, to spend time one-on-one with these physicians. It's not a survey instrument. It's not a phone call. It's not a mass meeting of physicians. It really requires individual attention, building of trust, and over time to get physicians and organizational leaders together on the same page.
Great. Thank you both for sharing your insights with the audience here today. It's been very insightful. We do have some time for questions here. So as a reminder to our audience, if you have a question for Dr. Pryor or Dr. Lambert, and you're logged into the webinar online, please access the questions pane on your attendee interface and feel free to submit a question to us through that channel, and we'll be on the lookout for additional ones coming through. We have a couple already at hand to kick things off, and first one is a fairly direct question, which I'll pose to you, Dr. Pryor. Just when will we actually need to worry about all of this? Can you kind of comment back on that, if you would, please?
So I think we have this history of the Congress kicking the can down the road to trying to fix the SGR year after year until they finally fixed it. So one of the things that we brought out in the discussion was that the first baseline reporting period and data gathering period starts in January of 2017. So right now is the time to start worrying about it and to start understanding the implications of the new pay-for-value type of payment. And so the time is now.
Very good. Thank you. Dr. Lambert, as a health system board member yourself, can you comment on what is the role of the board in facilitating the migration of physicians to a more engaged and aligned position?
Well, I do think that the board, of course, has the fiduciary responsibility for the organization. So I think it is important for the board members to be actively involved in this kind of trust building, education, engagement, and dialogue with physicians on a regular basis. This is not just something that should be left to the executive team or the C-suite. After all, if indeed the statistics that I offered to you about CEO turnover and turnover of other key executives is operative within your own organization, it's the physicians, the board, and the employees that represent the most stable functions within any organization. So I think it's essential that the board members be intimately involved with this, that they develop relationships and understanding of what's going on with the people practicing in their organization. And I think they can be extraordinarily beneficial. Most of them come from business backgrounds, have been very successful in their careers. So they understand change and the need to change, and they can be extremely effective at carrying this message to the physician community.
Thank you. One of our attendees is commenting that the amounts of money at risk don't seem to be enough to motivate most physicians, at least until it gets to maybe 15 to 20% of all reimbursement. The attendee is saying most of the physicians don't care. So can you provide some perspective on how to deal with that, either of you?
Well, first of all, by 2021, the adjustment will be around 18%. So, of course, beginning in 2019, it's only going to be 8%, but that's approaching the 10% mark for Medicare Part B payments to clinicians. I guess if you don't take Medicare and you're not a Medicare participant, then you may never have to worry about it. But as you get more and more of the payers that are going to start switching and following CMS's example, there'll be more and more that will be in the pay-for-performance type of and pay-for-value realm of reimbursement. So it won't. I don't believe it's going to stop with CMS. I believe it's going to bleed over into commercial. Matt, do you have a?
I think I would just say that that this idea of I understand the whole issue of remuneration and how physicians feel challenged with the decline in reimbursement and unwilling to make change. But there are organizations that we work with on a regular basis that have somehow figured out how to engage their physicians in this process to the point that physicians are part of the solution, that they're actively involved in helping an organization move forward and be successful. We don't want physicians to devolve into sort of piece workers here. And we want them to be, part of the solution, part of the crafting of an organizational effort that ultimately is successful for the patients and the community. I think we've done a lot of damage with physicians, especially independent physicians, beginning in the 90s when we began to employ practices. Ultimately, those things failed, and now we're back at it again. So physicians have a right to be skeptical, but we're hopeful that the organizational commitment to this kind of dialogue will be helpful in engaging physicians on something more than dollars and cents.
Thank you. For physicians who are not used to any significant portion of salary being related to quality metrics, what is a realistic timeline to transition them? And how would you define first steps in making this transition?
Well, it's surprising to hear the question, unless I'm not understanding it completely. But I think most physicians are endeavoring to practice the highest quality care all the time with all of their patients. I think it's the rare physician that I think is inured to that type of parameter. I think it's a matter of helping physicians understand what might be coming down the pike with respect to the quality metrics. Bob alluded to the fact that most of these are really process metrics. Did you give aspirin? Did you do this? Did you do that? They're really not that closely related to quality. But I think in helping physicians understand what they can do within their practices to generate better outcomes using evidence-based medicine, identifying best practices within the organization with which they may not be familiar, and trying to anticipate based on the most up-to-date data where they might be called to task in the future regarding quality metrics.
I think one of the problems is that we physicians for years really didn't have any insight on our own true quality data metrics because nobody gave us our data metrics. Now there are several products that are coming on the market that are able to slice and dice a lot of data and give report cards to physicians about exactly how well are you doing. And in some of them, they can actually compare a physician's performance to a benchmark. And I think once physicians understand clearly where their data is leading their practice, then we physicians will self-correct and practice quality medicine, because that's at the heart of everything we do. That's at the heart of it. It's practicing high quality medicine for the patients who come and seek our care.
Another of our audience members is commenting that most of the time in most settings, accepting more risk comes with the promise or chance of increased reward. And their feeling is that the disconnect over the years is that the reward has not kept up with the increased assumption of risk. Do you agree with that?
Well, there certainly in business there is a premium for accepting risk. There's a premium for accepting risk. I think unfortunately what's happening is that this is going to be a zero-sum game, and they're going to take the money and they're going to divide it among a spectrum of quality or process indicators, and the risk reward may not be more money, but another way to look at it, it may be less penalty.
Okay. We have a question. Another question: is it true that the value-based purchasing modifier is set to impact some physician practices this year, perhaps practices of 100 or more? Do you have a comment on that?
I'm not sure about the number. There is a break. We'll have to get back with you on that one. But the adjustments that are coming, and you may be talking about the alternative payment model, because that is the alternative to the merit-based payment. So you're going to be in one or the other. The alternative payment model has criteria in which that you need to make before you can get into the APM branch.
Very good, thank you. Coming back to that subject of clinical variation, one of our audience members is commenting that clinical standardization is necessary to address unwarranted clinical variation in the value world. What have you seen worked well when performing this type of work? Any perspective on that?
Well, I think, I'll make a comment first, and I know Bob has had experience in this. I think that, what works is it has to be a physician-led and a physician-driven process. I think getting physicians together and giving them information about, let's say, the cost of a particular resource, and acquainting them with the expenditure of that resource within the organization and how that resource may be deployed among different types of resources or different brands of resources. You know, the most typical example, of course, is the use of a orthopedic prosthesis, or hip replacement, knee replacement, and physicians are trained differently, and they prefer a particular type of prosthesis over another. And sometimes, as most of you on the phone know, there are wide variations in cost to the organization that sometimes are not really segmentable by the quality outcomes that basically occur with each of those different prostheses. So I think getting physicians and presenting them with a problem to solve and allowing them to solve it on their own is the best way to deal with unwarranted variation, regardless of what type it is, whether it's antibiotics or chemotherapy or prostheses, suture material, all of those kinds of things. Physicians are in the best position to help solve those problems rather than having them mandated by some other person in the organization.
I absolutely agree. I've seen evidence of where groups of physicians have gotten together and found the best way to care for the patients at the lowest cost. And when the physicians get together in a best care committee or a best practice committee and standardize, then there's a lot of ripple effects to that. Number one is that if you only have one type of or two types of prosthesis that you're doing in an operation, then everybody in the operating room knows what to expect as the case proceeds. But if you have 10 different variants, then most people are confused as what goes next, and you don't have as many eyes watching the quality of the procedure. So it's not just a cost, it's also a quality metric as well.
Thank you. Dr. Lambert, you emphasized the importance of one-to-one interaction as part of this effort, but how often should clinicians, physician administrators, and C-suite health system executives meet to most effectively implement this delivery model? And related to that, should IT, finance, and other departments be involved consistently as well?
Yeah, I think, you know, as I said, you know, in order to have an effective organization or effective health system, everybody has got to be playing together. And my own personal feeling is that people on the executive team need to get out of their offices, get in their cars, and drive out to the physician's office and periodically sit down with them just to see what's going on. You know, show some interest, show some concern. Try to figure out if there's some way the health system can help them you know, within their day-to-day environment. Maybe it has to do with patient registration, laboratory retrieval, and any number of other things. But the fact is, if you're digging a ditch and somebody comes by and helps you dig it for even 5 or 10 minutes, you're grateful to them, and there's an establishment of some sort of obligation in some respects, that if you're doing something for someone, they'll do something for you. So I don't believe that any organization is going to be successful with some sort of mass mailing or mass meetings or email blast or whatever it might be. This is the responsibility of the C-suite and every other executive within an organization. They may need to be assigned physicians on a rotating basis to go out and actually interact with them, in the hospital, to make sure that their problems are obviated to the extent that the system can do that. And I believe that generates trust and confidence and a much more of a willingness to engage in this difficult work of moving from a fee-for-service environment to a value-based environment.
I think that works in a lot of instances. I'm curious when I go to an organization and I ask if they've communicated this, and the answer oftentimes is yes, we send an email out to everybody. Well, that's not communication. That's information that goes out. For communication to occur, it has to be two-way. You have to put out a claim and then have a chance for a counterclaim and then a discussion based upon the claim and counterclaim to come to a decision and a good outcome. But just sending out an email is not communication, but in many organizations, that's what suffices for communication.
Thank you. Coming back to the subject of motivation, we have an audience member commenting the combination of extrinsic and intrinsic motivation seems to be powerful. They're asking, have you seen unique extrinsic models that were more long-term oriented so they reinforce the intrinsic motivators? Any thoughts there?
Well, I wish I could talk to the questioner directly to get a little bit more clarification. I think that, like I think Bob and I both believe, physicians are already fairly intrinsically motivated. I mean, this is a tough profession. I don't think, regardless of, regardless how much money physicians make or may have made in the past, the fact is it's a tough business. It requires an extraordinary level of commitment and sacrifice. Family, friends, personal life, and things like that. And I think most physicians have that intrinsic motivation as healthcare professionals. I think the extrinsic motivation can be something other than just dollars and cents. I think there's a lot of things that can be done to make a physician's life easier, to generate more quality time when they're in their office. If they're an owned and operated practice, they ought to have the ability to help select the people that work in that office, and a lot of organizations don't allow that. That creates an unfortunate dynamic within the office. But I think there's a lot of things that can be done for physicians that are extrinsic motivators, but not necessarily the quick and easy, just pay them a few dollars more.
We have time for maybe two more questions. So we have another question regarding coming back to the topic of MIPS, Dr. Pryor, that you covered earlier. Even if everyone improves and meets the criteria, the audience members asking 50% of providers will adjust up and 50% will adjust down is the assumption or the perspective. Is that your understanding of the financial piece at risk in MIPS?
It will be a zero-sum game. There won't be any more money there, so there'll be winners and losers. And this is where knowing your own data and knowing your data in a relative performance way is going to be very important in moving forward. You have to understand your own data. What's happened in the past is that the insurance companies know your data, the government knows your data, but we physicians have not been privy to a lot of our data that's out there. So it's going to be incumbent upon the organizations that we're within and us ourselves is to get our own data and understand our data.
Very good. And I think we will close it out there actually as we're just about at the top of the hour. I want to thank the audience members for joining us here today and for the excellent questions that were submitted. Again, if we did not get to your question here today, we'll certainly take note of it and look to follow up with you after the event. And as a reminder, this presentation has been recorded, and you will receive a link to access the recording tomorrow if you'd like to revisit the content or if you'd like to share it out with your colleagues who are not able to participate today. The presentation that we reviewed as well is accessible through the handout section of your interface, so please take the opportunity to download it if you wish to access any of the content. And then as a note, as indicated on the screen here, this is the first webinar in a three-part series we're conducting in association with the American Association of Physician Leaders. Our next webinar will take place on August 10th, covering the topic of physician compensation or value-based payment. And then the final webinar of the series is slated for October 5th, getting the topic of new era metrics for physician performance. So if you've not yet registered for those two webinars, we encourage you to do so. You can do so via our website, kaufmann.com, where you can also access a wealth of educational material on that website as well. So please take the opportunity to visit the site, register for these two upcoming webinars, and access other educational material. Again, we thank you for participation, and thank you as well to Dr. Pryor and Dr. Lambert for their thoughts and insights here today, and we wish you all a good day.